Hi, everyone. My name is Elena Lattis. I am a professor at Columbia University, located in New York City. So, greetings from the US to all of you. I have been working in pediatric oncology for the past 20 years, focusing on how to improve nutritional status so as to improve survival and reduce treatment-related toxicities in childhood cancer. A lot of my work started in the United States. However, for the past about 10 years, I've really focused a lot of my work in low and middle income countries to help improve the level and quality of care as well as the education in the provision of clinical nutrition for childhood cancer. So I'm delighted to be here and talk to all of you. And I will take any questions in the question box. Are we holding questions to the end, or how is this working?
Um, yeah, so just a brief overview. We normally have the presentation first. The audience will address the questions on the question and answer panel. And then at the end of the discussion, we'll start answering the questions. Uh, yeah, I think that wraps it up.
Okay, okay.
Yeah. Yeah, so just before you start, we also have Dr. Irene Zalmo as part of our panelists today. Dr. Irene, how are you?
Fine, thank you, Dr. Amina. Thank you.
Yeah, Dr. Irene is our pediatric oncologist. She is here to give moral support to all of us. Yes, Dr. Professor, you may start the presentation.
Okay, thank you again. Thank you for the invitation, and I look forward to hearing the discussion afterwards. So, as mentioned, I'm going to speak about the importance of nutritional status in childhood cancer, the clinical implications, and some solutions that we have implemented, one of which in collaboration with KNH to help improve outcomes for childhood cancer. Okay. So the first question we need to think about is, should children with cancer be stratified at diagnosis based on nutrition status? So for those of you who work in the field of pediatric oncology, you know that a patient, or maybe if you don't work in pediatric oncology and you've had experience either personally or with a friend, family member with cancer, you know that cancer, it's not just a diagnosis, it comes with a stage, it comes with all other kind of implications which dictate the kind of care that a patient receives. But we propose, and by the end of this lecture, we think that nutritional status should be one of those components that's considered. However, it gets complicated because how do we define nutritional status? What constitutes an at-risk nutritional status? Is it simply by BMI? Or do we really need to look at more in-depth composition, such as body composition? Is the effect the same across different diagnoses? We know from a lot of data in acute lymphoblastic leukemia that nutritional status at diagnosis and throughout therapy impacts a child's probability of surviving and impacts the number of toxicities they get. But we don't know that across all diagnoses. Are there modifiers of this effect? And then what is the level of evidence? So here I want to show you, just as an overview, in general, we know that there's disparities for treatment for cancer in low and middle income countries. And you can see here on the left of my screen, here's survival and cure, which hovers around 80% in high income countries. And then when you look at cure in low and middle income countries, overall globally, it hovers around 20%. And there's many reasons for this. But, a good portion of them are preventable deaths, what we consider preventable deaths. So things such as fatal toxicity, treatment completed, making sure that the patient starts treatment and then finishes it, that the treatment is initiated and they have access to it. It's a correct diagnosis, and that there's actually a cancer diagnosis. But some of these events here that are preventable are influenced by nutritional status. So we know, again, from much data that toxicity is impacted by nutritional status. The ability of a patient to complete treatment is predicted by nutritional status. And if their treatment is completed, it's predicted by nutritional status. So this was one of the first studies that showed that poor nutritional status, reduces survival. And I want to underscore to the audience that when I'm referring to nutritional status, I am referring to the double burden of malnutrition. So we all well know that, most usually when you think of an individual with cancer, you think of undernutrition. However, with the growing population of overweight and obese children and adolescents, that is also becoming a risk factor. And you can see this from this figure here. This line here is survival of patients who have a healthy weight. So the probability of survival exceeds, this is for AML, exceeds 50%. Now, when you look at underweight and overweight, it's significantly lower. So we have an odds ratio for decreased survival, about an 85% increased risk of reduced survival for patients underweight, and for patients overweight and obese, an 88% increased risk of reduced survival. And what I think is one of the most important aspects of this study is one of the quotes from the discussion. And it says, the effect of BMI on outcome in pediatric AML is not a trivial problem. The reduced survival in underweight and overweight patients is roughly equal to the improved survival accomplished by 10 years of research of progress in AML. So this is pretty astounding, especially because we know that nutritional status is modifiable. If you're underweight at a given time, if you're obese at a given time, we can fix that. And with proper intervention, we know we can be successful at it. So we did a large meta-analysis, and what we did was we compiled all of the data. Again, right now I'm limited to high-income countries. All of the data in pediatric leukemias, both acute lymphoblastic leukemia and acute myeloid leukemia. And we said, okay, what is the association in this cohort of 8,000 patients of nutritional status on survival? And what we found here is that patients that were overweight or obese had a 35% reduction of survival. What we also found in subsequent analysis is that if you remediate, if you redress nutritional status, so if patients are underweight and you bring them to a healthy weight category at diagnosis and maintain that throughout therapy, or if they're overweight and you reduce that the odds of survival are more or less the same as someone who was in a healthy weight. Now, let's move to the low and middle income setting. We have a bit of data, not a lot as much as we do in high income countries, but we do have some data from Central America. And what this group did is, this is a Pediatric Oncology Consortia located in Central America. And they reviewed almost 2,000 patients undergoing treatment for ALL. And what they found here is that poor nutritional status, so this is the severely depleted at the bottom of my screen here, and then you see these two orange arrows, was associated with death, but it was also associated with abandonment of therapy. So remember when I showed you that first graph, treatment completion, that nutritional status is tightly linked to treatment completion. And we also found that just 2-year survival was also linked to how nutritionally well a patient was. So this group also tried to then replicate what we did in high-income countries and said, okay, well, if you intervene and you remediate the nutritional status, what happens? So again, they did an intervention study in 331 kids with ALL. And in figure A, you see survival. This is healthy weight patients. This is poor weight patients, a huge survival difference. But then look at figure B, and I point to this orange arrow and where my cursor is. This dotted survival are patients that were malnourished at diagnosis, so they were in this bottom grouping, but then intervened and got into a healthy weight, and you can see their survival, was deviating from healthy nutrition status, but in the end, it was the same as those patients with healthy nutrition. So those two studies really underscore the importance of interventions with nutritional status. Now we know that undernutrition at diagnosis is widely prevalent, and it's more prevalent in low and middle income countries than high income. And high income countries were really still managing the growing population of overweight and obese patients, while a very small percentage of ours are undernourished. And you can see that up to 60 to 70% in Africa are classified with undernutrition at diagnosis. And to couple this, there are many challenges faced by pediatric cancer units in low and middle income countries. So often there's limited time and personnel, and quite frankly, many of the sites that I have worked with don't even have access to nutritional care. So redressing under or over nutrition is extremely challenging if it's just the oncologist and the nurse that has to do this, because their time is limited in just delivering the life-saving chemotherapy. There often can be limited access to nutrition interventions. So patients may not, and institutions may not have access to F75, F100. They may not have access to nasogastric tubes. The issue of severe acute malnutrition. Many patients at diagnosis present with not only cancer and often an advanced disease, but with severe acute malnutrition. And this often is coupled with endemic rates of malnutrition within the countries. So we have multiple factors that are posing challenges to low and middle income countries to address poor nutritional status for children with cancer. So we have started an initiative called the International Initiative for Pediatrics and Nutrition, and this is based out of Columbia University, but it is a global program that's really striving to address this disparity in what I believe is modifiable and fixable, as long as we have well-trained clinicians who know how to manage under and over nutrition. And so the goal of this program is really to train clinicians in low and middle income countries in managing nutritional care for those kids that have chronic disease, which includes cancer. So we know that pediatric oncology is growing around the globe, and there's many reasons for this. One reason is that there's improved access to high quality pediatric cancer care in many countries in Africa. I think a decade, even 5 years ago, it was a lower percentage than it is today. So with that, there's more and more children that are accessing care and presenting to these institutions. At the same time, we know that endemic rates of malnutrition are still widely prevalent. I think now with COVID-19, that has only made it worse. And we know that about 30 to 80% of children are malnourished at the time of diagnosis, which delays treatment and reduces chances of survival. But again, at the same time, we also know this is an illustrated case sample from one of our sites, that if you can intervene quickly, timely, and with the proper access to interventions, that this can be fixed. So we know, poor nutrition, decreased survival, treatment delays, high cost of care. So, governments, institutions don't want patients who are both under or overnourished, because it increases the cost and the quality of their care. But again, we know that improved nutritional status has overall great outcomes for children. So our vision in collaboration with so many of our partners around the globe is to improve the quality of life and survival of children with pediatric illnesses, and to bring the most effective evidence-based nutritional care to these children around the globe. And we're headquartered in New York City, but we have many sites around the country, including Columbia Global Center, located right here in Nairobi, Kenya. So we have a global team that is collaborating on advancing nutritional care throughout the globe. And what's important is that IPN works with a number of high-profile partners. So we're very much involved with the World Health Organization, and especially with their ongoing initiative that is advancing access and quality of care to children with cancer located in low and middle income countries. We are also advancing some really interesting research in collaboration with the International Agency for Research on Cancer, which is the World Health Organization's research arm, and I'll talk a little bit about that in a moment. And then we have regional consortiums such as Children's Oncology Group, INCAP, which is the Institute of Nutrition in Central America, and of course the International Society for Pediatric Oncology. So here's our global presence, and again, you can see here, and with the focus here on Africa, we really have a strong presence throughout Africa, and I think opportunities to have within continent collaborations on clinical care research, and certainly to host forums like this where we can share case studies and experiences together. So our approach is first to build capacity, because as I mentioned before, through our research, especially in Africa, we found that many collaborating hospitals, they just don't have the resources to provide nutritional care. So IPN often hires and trains local clinicians and nutritionists to address that. That being said, we also need training and education, and we need training and education at all levels of clinical care, not just at the nutritionist level, at the nursing level, at the social work level, psychology, and physician. And then finally, evaluating the efficacy of these approaches through science, through program monitoring and progress, and through assessing global and regional needs. And one way we've done this is developed a framework on adapted nutritional care for children with cancer in low and middle income countries. And again, this report is quite extensive, and if any of you have questions, I'm happy to address it. But essentially what we did was, based on a region, based on the access to nutritional services within an institution, we're able to stratify and adapt the level of nutritional care to do the best we can within the constraints of the institution. And we know that this is successful because we've been able to increase the quality of care in many of our IPN sites. So our IPN sites are rated from a level of 1 to a level of 4. And here, just as an example, in Central America, we've increased care in 2 of our sites from a level 1 to a level 2-3, which is quite exciting for us. And this is expanding throughout Sub-Saharan Africa, especially in East Africa. We're doing similar, we're accomplishing similar progress in terms of advancing this level of care to higher quality care for children. So I mentioned research, and again, I don't want to go into this in great detail, but just to give you ideas of opportunities within your own centers, that there's a lot of excitement and a lot of encouragement about collaborations within institution and between institutions regionally, in terms of answering some really compelling questions. One of which is the role of the microbiome in outcomes in pediatric cancer. How do socio-demographic factors, food security impact these outcomes? And again, looking at all of these approaches within a standardized format. So ensuring standardization first along clinical care, ensuring the provision of clinical care is standardized. And then once that established, ensuring that the quality of care is standardized and the data collection is standardized, so we can start learning about interesting outcomes by different countries and different income levels with different resources and different endemic issues, facing not only themselves but clinicians. So our vision for the future is that nutritional status should not reduce survival in pediatric oncology. And, cases such as this should not be the face of cancer care. We really, through appropriate collaboration, education, and training, we can optimize outcomes and work in partnership with our oncologists and nurses to achieve the best odds for survival. So I'd like to thank everyone. I think I was told between 20 and 30 minutes, so this is just 25 minutes. So I will take questions and comments.
Wow, Professor, you are very timely. Thank you very much for the educative session. I think I can speak for most people. We have learned a lot, especially on the nutritional influence death. I think that one touched me the most because it's quite sad that cancer is not the only reason why people are dying. It also has something to do with their nutrition. Today, I'm not seeing a lot of questions from the people. Kindly address your questions in the Q&A forum. Before probably the people who have raised their hands, I can give you a session to speak. John Murica. John, how are you? Dr. Kirochi, do you want to say anything? Ask a question?
No. Sorry for raising my hand. Sorry.
Okay, no problem. Professor, I have a question. Mine is regarding the BMI. Do you think the BMI is the best indicator for nutritional status? Are we looking into having other indicators, or what's your thought on that?
Well, I think that's a very good question. In childhood cancer, we do know that, a term used as sarcopenic obesity often occurs in childhood cancer. The way to assess that is often through evaluation of body composition. And we also know that, children with cancer, especially those presenting with advanced disease, the BMI is not a useful indicator of nutritional status because it's altered by the tumor itself. We at IPAN, body composition is very difficult to do in an LMIC setting. I know in Kenya, the resources are quite different than some of the other countries in Africa, but we usually rely on a combination of BMI and mid-upper arm circumference. We can't use one without the other because it really depends on the clinical condition of the patient. So if the patient, comes with edema, large tumor burden, height is okay, but weight is, pretty much not helpful in that setting. And you really need to use MUAC as an indicator of nutritional status. And then what's most important is to chart the patient on either WHO or other Z-score charts for children over the age of 5. But great question, and it's a real hot topic in research right now.
Interesting. And how about micro deficiencies, like nutritional ones? How do you check that?
Yes, that is important as well. At this point, most of our IPAN sites, and again, I'm referring to Africa alone, but most of our sites are limited to clinical diagnosis of micronutrient deficiencies. It's difficult for many of them to get lab values still. If there's a suspect at a clinical level, we then dive into the laboratory indicators. But that again is very institution specific.
Okay. As somebody is asking, which is the most common type of cancer in children and how can it be prevented?
That's a good question. So I don't think that we know that at this point. I mean, the most common type of childhood cancer is acute lymphoblastic leukemia. However, in regions that varies by the globe, in Africa, retinoblastoma is also quite common. It's more common there than it is in the United States, and Burkitt's lymphoma is also more common in Africa than it is in the United States. I don't think we know how to treat, how to prevent childhood cancer. Some feel that it's, happens in utero. Some could be exposure to viruses. Some, let's see, I don't know, Dr. Zamu, I don't know if I'm missing anything. I think largely we don't know how to prevent it. But I do think that once a child survives, we do know how to reduce late effects and prevent recurrence through a healthy lifestyle. So Dr. Nazmu, I don't know if you want to add anything in terms of risk of childhood cancer.
Thank you, Prof. Elena. It's exactly as you've said it. We do not know how to prevent childhood cancer, but our message tends to be mostly towards early detection, so that we detect them early, treat them early, and then prevent the long-term complications. Because like Professor has said, it's mostly cytogenetic lesions, mutations, exposures, viral infections. At times, maybe one cancer like hepatoblastoma, there could be a role of vaccination against hepatitis B. But majorly when it comes to screening and prevention in childhood cancer, we do not have a big role there. Our biggest message is on early detection, early suspicion, early diagnosis, so that we can be able to treat and cure these children. Thank you.
Thank you, Dr. Nzamu. I just have a question regarding the Makori. Makori is our head of nutrition. I don't know, Makori, can you hear me so that I can be able to ask you a question?
Yes, I can hear you.
Yeah, welcome. Makori is the head of nutrition in KNH. So I just wanted to ask, what are the observed impacts that you have noticed since incorporating a nutritionist in the pediatric oncology clinic? Because it's one of the few clinics that has a nutrition on board. What's the impact? Probably you can give us your perspective, and Dr. Nzamu can also share on their experiences on the outcome of patients in KNH.
Well, I can speak actually from institutions that, we're in 27 hospitals at this point. In many of them, they had no nutrition service prior to IPAN. So we've completely changed the landscape of, the quality of care. And KNH is unique in that there's an amazing nutrition team in place. So I think for KNH, it's really augmenting the wonderful skills that are already present. I do want to know, address in the Q&A, yes, we are working with Uganda Cancer Center in Kampala. That was a question in the chat box.
Yeah, I noticed you're doing a lot of work in both Tanzania, Uganda. You've been to many countries, and I love the fact that you're standardizing the tools so that we can be able to get more or less the data that is informing us about what's happening in all the regions. Thank you for that work. It's quite important work.
Thank you.
Yeah, for Makori and Dr. Irene, maybe a few comments on your observations, especially on the impact of the program.
Well, thank you. The program is yet to start in KNH. But when we have a nutritionist in the clinic, there is a better follow-up, and any challenges that I experienced they discuss with the nutritionist in the clinic. There is that one-on-one, which has been found to be helpful. Thank you.
Thank you. Thank you, Irene. There's a comment in the chat box about nutrition charts. I'm not entirely sure what you mean. So we recommend the World Health Organization nutrition charts. I think what I can't stress enough for pediatrics to monitor height and weight and MUAC over time. So it's not just, patients diagnosed, we look at their nutritional status and we don't look at it again. This is a fluid assessment, and it will fluctuate tremendously. So, I think the most important thing is to assess and continue to reassess, because you also need to know if your intervention is working. I think it's same with adult cancer patients, but you can use absolute BMI there. You don't have to chart them on a growth chart. In terms of carbohydrates, yes, I think in most parts of the globe, carbohydrates are a part of the diet. I don't know if your question is related to the relationship with carbohydrates and cancer. So I'm not sure how to answer that. But yes, they do eat carbohydrates, but I don't think it's different than with cancer or without. I would say the only exception is in patients receiving steroids for a long period of time or high dose steroids, carbohydrates often become their best friend. I'm just reading some comments in the chat box.
So
yes, so this is a really good comment about the role of community nutrition and local cultures and myths on cancer. I think this is really about education, and they've done a lot of this work. There's a nurse in actually Cameroon that has done a tremendous job in actually going out, speaking with traditional healers, talking to them, educating them on causes of childhood cancer, and really kind of trying to collaborate with them instead of them staying separate. But that's a really important point, and something that really has to be addressed when counseling patients. In terms of lymphoma, yes, there's several types of lymphoma that occur: non-Hodgkin's lymphoma, Hodgkin's disease, and then there's some rare types, but those are Burkitt's lymphoma. Actually, that's probably most common. Again, I'll defer to Dr. Nazmu on the most common, but I think in Africa it might be Burkitt's, but I'm not 100% sure.
Yes, Prof, we have a lot of buckets. It's commoner than the other types of non-Hodgkin lymphoma. Very few get ALCL, few get DLBCL. Those are the other types of non-Hodgkin's lymphoma, lymphoblastic lymphomas. But for us here, the commonest is actually Burkitt's. And then we also have Hodgkin lymphoma being quite prevalent. The other types of non-Hodgkin's are very few.
Thank you.
Yeah, thank
Thank
you.
goodness Dr. Nazmu's on the phone.
Yes. Yeah, there's somebody asking about the psychosocial aspects. Do the patient, what are the psychosocial aspects patients face when it comes to assessing their nutritional needs?
So
Probably,
again, this is
Professor, you could speak about the high income, and either Makori or Nzamu can speak regarding to our settings.
Yes, this is again a really good point. I can't stress enough that ensuring that, don't use nutrition as a tool for coercion to get children to eat. I see that all the time. And it's hard enough if they feel sick. And maybe I see it mostly with, kids with SAM, and, they don't want a nasogastric tube, or they don't want to go to other forms of advanced nutrition. And, you use it kind of as a penalty. And that's really detrimental to the psychological well-being. It's really difficult for these kids often to eat. It can be a tumor blocking, GI tract. They can be releasing biological chemicals that, impede nutritional intake or the desire to eat. So there's so many factors that can go into this, but I think, the most important thing is to not use nutrition as a penalty for not, for poor weight gain. There's another question about immunity, carb, sugar, alcohol. Okay, so
sorry, Professor, before we answer the next question,
okay.
I just wanted to, for the audience, because they're all interested to knowing also on what's happening on the ground here. Probably, Makori, you could shed light on the psychosocial aspects of patients when it comes to nutritional needs, considering most patients can't afford many things here in Kenya. What are we doing about that? I believe there's also Emily Kendi. Maybe you could answer one of the questions, that specific question. Okay, probably they're having technical challenges.
Or maybe they need to unmute.
Yeah, I don't know. But maybe we could go on. Professor, I'm interested to know, when do we choose to go on more invasive methods like do TPN or do the stoma? We introduce a gastro tube. At what point do people decide to do that in pediatric oncology?
Well, we have a lot of algorithms that we follow in terms of when the optimal time is to do more advanced levels of nutritional care. Often, sometimes it's dictated by weight loss, it's dictated by tumor burden, location of tumor, and then what the planned therapy is. So there's a variety, and I should add, actually very important, what is the home environment of the patient, and can they manage a nasogastric tube at home?
Okay. So there are guidelines, which are available.
Yeah.
Okay. Thank you very much. There's another very important question regarding appetite stimulants to promote food intake. Is that really useful in children?
So the evidence is mixed. There's, the problem with appetite stimulants is the one that has the most evidence is also immunosuppressive, so it's not used frequently, and it also is unclear if it promotes weight gain or just water retention. So there's been some trials, but there's no perfect antidote to that. There's a question about carbs in cancer. Yes, I do. I mean, certainly complex carbohydrates are always going to be more beneficial than simple. There's no question about that in the presence and with and without cancer. So I would say yes, carbohydrate intake, but the focus being on complex carbs.
Professor, if I may just clarify on that question regarding appetite stimulants. What are appetite stimulants? Because to most of us, it's multivitamins. Are there other forms? Because our practice here, I think we mostly give tresorics or just multivitamins so that it can stimulate your appetite.
Well, there's no evidence that multivitamins promote appetite. So I'm referring to things such as megase and periactin, cyproheptadine. That's what I'm referring to, actually pharmaceutical level.
Okay, that's interesting. I don't know if we have those in our setting. Do we have that, Dr. Zamo?
Yes, we have. We do have cyproheptadine is Tresorics, which is very common in our market that people are always prescribing, and that's where we are saying evidence is conflicting, and really there is no evidence that we should be giving these ones to our children with cancer to stimulate appetite. Yeah.
I think that's a very vital information. We normally prescribe tresorics, which is septoheptadine, but we don't have that knowledge in the background, which is, I believe, it will go a long way. How about water retention? My understanding of water retention, how does it affect BMI and mid-upper circumference? Does it give us false information, especially in patients who have a lot of fluid retention because of probably kidney failure or what have you?
Well, kidney failure isn't really that common. I mean, it's not something that's routine in pediatric oncology, kidney failure. I mean, unless there's, yeah, it's actually not common at all. Sometimes with certain therapies, they can be toxic to the kidney, but in very rare cases, I don't know. Again, Dr. Nazmu may say differently, but we don't see it. It's extremely rare if we see that. So water retention can occur because of usually because of the tumor or steroids. Those are the two
main reasons.
I think, unless again, I'm going to turn to Dr. Nazmu to see if she has more insight on that.
Yeah, agreed. It's not common to see, but I was just asking in the context of even when it's not oncology we're talking about, just generally, how does the impact of fluid retention affect things that we use to actually gauge nutritional status, like BMI, mid-upper circumference? How does it affect in general, aside from pediatric oncology, if you're able to answer that?
I think you just adjust accordingly, using mid-upper arm circumference when needed, or usually. It's not something that precludes nutrition intervention.
Okay.
There's a question about, which type of pediatric cancer has the, worst outcomes. I would probably say brain tumors, some sarcomas, but I would say probably brain tumors. Again, Dr. Nazmu, if she has other comments on that.
Thank you, Prof. I agree with you. But that question again is asking us the deadliest type of pediatric cancer. It would really depend, because even leukemias and lymphomas can be very deadly when they've come in with the oncologic emergencies, like tumor lysis syndrome, upper airway obstruction, superior vena cava syndrome. So the deadliness of the cancer would depend on how they present and how quick we are able to really intervene and salvage. And also on the stage, again, being deadly would mean